And hi, I think we've had a couple other people join. Who's on the line as well?
Hey, Brian, it's Dr. Kerschel, Chief Medical Officer from Cerner. Thank you so much for the invitation.
Of course, yeah, thanks for joining again and listening in.
My pleasure.
Yeah. And do we have Dr. Grace Wu as well? I think I see you out there.
Yes, I'm here.
Okay. You probably have a speaker on, maybe on your computer as well, or a phone.
Okay. I think I fixed it. Yes, I'm the CMIO at Low Regional Medical Center.
Great. Thanks for joining.
Thank you.
Yeah.
Hey, Brian, it's Pat Brown.
Hey, Dr. Brown, thanks for joining.
Sure thing.
Hey, Brian, Dr. Mandy Halford is here.
Hey, Dr. Halford.
How are you today?
Good, how are you?
Good.
All right.
So, Brian, I see one other person has joined, Craig.
Hi, yes, this is Craig Lamoli from Wellsheet. Nice to meet you all.
Hello, Craig.
Great. Dr. Brown, Dr. Wu, once we get everybody joined, I don't think you've done introductions or discussed your site or anything. So I may have you do that here once you get a couple other people. So that way, give you a heads up notice. I won't put you on the spot for it.
Okay, that's fine. Thank you.
Yep. Did have a couple other folks who said they may be joining in a couple minutes here. We'll give it maybe one more minute and then we'll go ahead and get started. I know we have 90 minutes, but we won't have University of Tennessee be able to present for innovations today. Dr. Clay Callison actually is back in clinical rotations through the ICU. So this actually is one of his days. So this did not work out. So we'll probably move him to the October meeting and he can present then. So most likely we won't go the full 90 minutes unless you have a lot of questions or things like that that we want to get into during the open discussion as well. We're about 4 after the hour, so I'm going to go ahead and kick this off. Again, for anybody who doesn't know me, I'm Brian Cottonsteady. I'm one of the co-founders here at Make Solutions, and we've been doing these CMIO roundtables for probably 18 months or so. And really the idea is for CMIOs and physician representatives to get together and discuss what they're doing to improve physician satisfaction in the organization, improve patient care, and just being able to use Cerner as one of those tools to further improve what's going on. We try and make this, it's not a sales meeting, it's not driven by Cerner, it's just something that Patty, Marshall, and I, as we have been into different organizations, we continue to hear over and over again what are other organizations doing. So we're just using our contacts and our expertise to pull you together in order to be able to have those discussions. So these are all driven by you. And this particular meeting is what we call an innovation sessions, where we will hear from you about what you're doing. And today we have Dr. Khalid, who's going to be talking to us as a CMIO of Sidra Health in Doha, Qatar. So thank you for staying up late and being able to do this presentation with us, Dr. Khalid. We really appreciate it. Actually, I've had the pleasure of seeing him at that organization and seeing what a fantastic facility that is. And I know he's doing a lot of really neat innovations. And so I wanted to for sure hear from him as well. I will turn the floor over to him in a couple minutes, but we do have a couple new organizations with us this month. I wanted to give them a couple minutes to introduce themselves and talk about where they are, either on their Cerner journey or just their EHR and physician journey in general. So Dr. Grace Wu, did you want to start us off and give us an introduction?
Sure, thank you. I'm Grace Wu. I'm the CMIO at Murray Regional Medical Center. We're a 225-bed regional hospital about 45 minutes south of Nashville. And we did Big Bang Cerner conversion back in November 2018, so we're about 2 months in now.
That's great. Thank you very much. And I'll go to you, Dr. Brown.
So I'm Pat Brown. I'm a CMIO here at Centra Health. I've been with Centra since March of this year. Before that, I was with Bay State Health in Springfield, Mass. For 10 years as the medical director of informatics, and then with Mission Health in Asheville, North Carolina, where I got to work with Ashley Cottonsteady. I was there for 4 years as the associate CMIO. Centra is a sort of a health system. We have about 700 hospital beds plus ambulatory clinics. They went live with Cerner about 20 to 24 months ago, and my role now coming in is mostly trying to help to get the group to optimize the system and really keep it moving forward.
You certainly got there at a lively time there in that early March timeframe. You walked right into full COVID with them.
I did.
Hopefully you've been able to get your head above water now.
Yes, I did. Thank you.
Great. Do we have anybody else who's on that hasn't introduced themselves before? I think everybody else has. Great. Well, Dr. Khalid, I'll go ahead and pass it over to you. We can see your slides here on the screen. If anybody's not dialed in, go ahead and use that link within the invite that I have for the Teams meeting. You'll be able to see the slides that he's presenting.
Thank you, Brian. So good morning, good afternoon. I don't know what's the time there. Good afternoon, everybody.
Afternoon.
Okay, good afternoon, everybody. And thank you, Brian, for giving me this opportunity to speak about Sidra innovations. I think innovation, it is one of the important topics that especially we are, using, the electronic medical records. We always all the time optimizing the solutions for efficiency and cost effectiveness, and also to ensure patient safety. So speaking about Sidra, Sidra is a tertiary center mainly for pediatrics and women, and we are 399 beds. It's located at the state of Qatar. We are like a small country in the Middle East. So when you get the chance to visit Middle East, feel free to come and visit us in Qatar. So speaking about innovations, I make a few slides because I want to give the chance for my colleagues also to speak, and I'm happy to answer any of the questions. So when we started Sidra, we had innovations because innovation is one of our main values. So we had established infrastructures web-based where it collects all the thoughts and the ideas, and also it gives the chance for the team to work together and share ideas through, as a social networking. And so the people, they can review what's the ideas that is published, and then the people, they can work together as groups. At the same time, we try to put, challenges or some of the topics that organizations are interested. So we ask the people to brainstorm, focusing on these certain items. Like, for example, recently, there was asked from the country is to focus on technology related to support COVID-19 emergency response. So this is one of the initiatives where you can ask the people to focus on some of the interest. Other than this, we basically ask the people to be, open-minded and think out of the box of all ideas. And it's very important also at the same time to have a certain task force or committee who they can control these ideas, which ideas to support for implementation, because you want to make sure that there is no disruptive innovations. And also you want to tailor the benefits that can benefit the organizations. So we have our website that we established. It's called Ideas, and basically where the people, they can publish their ideas, and then the team, they will be able to see those ideas. It is open for everybody, and then they can basically share or vote and discuss, and also they can volunteer, and they can also ask to be working with the group. And then we do crowdsourcing and voting, and then it go to the committee where they can study, and then it go at the end to basically for the pitch day, and we support a couple of these projects according to the budget and according to the objectives and the needs for the organizations. So this is in general. This slide is showing you very brief, some of the technology that we have at Sidra. Sidra is considered like one of the digital hospitals. We are paperless organizations. We are not yet fully digitized. We still use paper, but very minimal. Most of the process that we have here is digital. We are having Cerner Millennium as an EMR solutions, and we have all the Cerner solutions. So in terms of the pharmacy, we established Safara system. This is we implemented and built by our team at Sidra. It is basically it is like a calling system, so where you can basically notify or call a patient either for a certain to come for certain test or to pick up medication. So basically the patient will receive an SMS that his medication is ready, so then he come and pick it up. So for example, if a physician prescribe a prescription and it will take time, the patients or the family, they can go around and set the cafeteria till they receive a message that the medication is ready for picking up. So then they go to pharmacy and pick up the medication. Swisslog robotics. This is robotics in the pharmacy where they can do the packaging for the medications. And Riva Report is basically a robotic for the IV medication for inpatient facilities. And OmniCells, I'm sure you know all about the OmniCells. It is a cabinet solutions, fully digitized and integrated with Cerner solution. So for in case of urgency, the nurse or the care provider, he can access the OmniCells and can pick the medicines rather than the medicine come from pharmacy and may take time. You can take it from OmniCells, and that will send a message to the pharmacy that that one medicine that had been utilized from the OmniCells. So everything is controlled. In terms of the clinical services, we established, like since March or even February, as a COVID-19 emergency response, the virtual patients consultations. So we have telephone versus videos, and some patients who they are high risk, we still calling them to come. And for the virtual consultation, we use currently the solutions name VC. I also in the state, I know that VC also common, they are using it also in some health organization in the United States. So here we are using VC, same thing. Also, we have Hug system. I'm sure you are familiar with that. This is for newborn. So we keep them on the foot. So basically to track them. So as some sort of safety. So and also there is an alarm that there is no baby will leave the units. So basically it will be attached with the mother all the time. And that will reduce, baby's abduction. Then you have the digital health. We have, this is some of the, the first two have been basically implemented here. We have 10 moons. I will speak with it in the next slide. And also we are trying to establish Sidra app to engage, like the public by sending some sort of information or new services that we have at Sidra. And Fosera, I'm sure you are familiar with the Fosera. This is, like a communications tools. We use Fosera and we like it. So this is hand-free tools for communications, and you can have it as an instrument or an app. So we have here most of our communication and Code Blue, we do it through Fosera. We have also pneumatic tube system for the laboratory. We have, in terms of the surgery, we have robotic surgery, 3D printers. We have the MRI built in OR. Basically, we have some ORs, especially for neurosurgery, they require an MRI suites. So we have MRI built in the OR, and there are 2 rooms. So the MRI actually moved from one room to the other room. So for example, if he's operating, and there is some of the machines that they are not compatible with the MRIs, so automatically upon the MRI introduced to the room, the other machines will go and the room will be ready for the MRI. They take the pictures, then after that the MRI will go to the other room, the room will be closed, and then they can operate. So most of the time this room will be utilized for invasive procedures or neurosurgery, and we are happy we have this technology. Everything is automated and the doctors, they like it. And also we have the Bone Expert artificial intelligence based solution, where it is automatically, it can read the patient's bone age rather than going to the textbook and searching for that. And also we have the vehicle, like the automated guided vehicles at Sidra. This is some of the solution. And also the other things, we have Sena solution, and we have, like a lot of machines that are integrated with Sidra, like all our monitors, equipment, they are all integrated with Sena solution. Currently, we are working now to integrate and working to have, like the Pepperone IV infusions. So this is what we are doing now. This picture, this is showing you the hug for babies to prevent baby subduction. This is for a newborn. This is the OR robotic, and this is the, like the robotic mobile system that we are utilized fully by the facilities. And this is the robotics for the pharmacy. It's called Riva for the IV medication management. So all the IV medications will be basically done by robotics, and then will be sent through the pneumatic tubes. And this is an app that we established here at Sidra. It's called 10 Moons. And the idea behind 10 Moons is basically to help mothers who they are pregnant. So it provides them a lot of educations about the stage of the gestational age, what's the expectation, and what's the time of visits, and in terms of the medication advice and everything. And also we can send their ultrasounds. So if they did an ultrasound, for example, they will have it through their app. So then she can review her ultrasound lab, and also she can get advice week per week about the expectation. So this is some sort, it's very helpful for the mother to know the expectation and the education at the different stages for the pregnancy. The other tools that we established is called Safara, and I mentioned this earlier. This is it's a queue management system, so it's very helpful. Like when you have patients and big space, so maybe the patients, maybe he's not hearing you when you call for his name. So we established this queue management system. So upon you register the patient will receive a message as SMS. And then he knows that he's due, then he will show up. So we are using the queue management system for the laboratory, especially if the patient is due for blood extraction and he's waiting so he can come, and also for pharmacy and for other services where you are expecting to see crowds of patients. So this is like, can manage the system queue, the public queue, so they can receive the services. So rather than staying in one place, they can go to any places, to the garden, to the cafeteria, and upon they get the message, they can come to collect their medication. Also, we have it is integrated with Cerner and messaging system. And also it's customized to our needs. So we can customize it for the laboratory versus pharmacy and other services, like medical records. So if we have a patient, so they are waiting for the medical reports. So if there are too many, you can call them by Safari. Also, this is other solutions called Code Blue. So you can use the app to notify, like the rapid response team if you have a sick child, and this automatically it will through the navigation through the Wi-Fi, it will identify your location. So it will notify the rapid response team with your location through the Wi-Fi. Currently, this is under process for testing. We are not using it. So we are using currently here at Sidra for the Code Blue, different tools of communications. Mainly we are using Coursera, and also there is a cell phone that we are using as a backup if the Coursera failed. So we are using cell phone. And if in case that we lost the energy or we lost, like the Wi-Fi or the network, we have also, like the overhead paging system that it can go over the whole building and to notify for the Code Blue, because we want to make sure that that we ensure that we get the help on time. But currently we see that Coursera is working very well, so we are using Coursera for covering the Code Blue for pizza and adults here. This is other solution. It's called Sidra Active Directory Anonymous Messenger. So we send this messages through the web page. So when the doctors or any providers basically open their computers at the working place, so every 4 months or 6 months, they get this message to notify them to update their number, like contact informations. Because here we get very frequent that some doctors, they change their mobile number. And the only way when he put his mobile number, we make sure that this is the right mobile number, because upon he put his mobile number, the provider will receive a message, which is the code in his mobile SMS. And then he need to put the code number there. If it is accurate, he will submit it, then that will update automatically the doctors or the provider informations within our registry within Sidra. And by this, we keep the information updated.
Who came up with that acronym, the annoying messenger?
Oh, this is some of the ITs. Those people because it's really annoying. Because you cannot you cannot get rid of it till you put the mobile number. You cannot use the computer, you cannot use your email or anything. It is very annoying because it will be there in the middle of the screen. So it will enforce you to put your number and update your information. And I think they put this for purpose to enforce the provider to update his information. And you get these messages probably every 4 to 6 months.
I'm sorry, how often?
Every 4 to 6 months.
Wow.
Currently they do it every 6 months now.
Wow.
Yeah, but it's really annoying. I think he's right when he put annoying, because sometimes even myself, when I get this message, it's really annoying. You cannot get rid of it. Okay. And in terms of the virtual consultations, currently we use VC, which is outside of Cerner Millennium. So the doctors will work on 2 screens, one screen supporting VC, and other screen he will open, like Cerner Millennium to do the documentation for the virtual consultations. And I found this is, not, practical. So now currently this is not live, but this is some of the ideas that we came with. We said we like to see, like the virtual consultation within our in-page workflow. So this will be like much better, like to support the adoptions, and it will be like more practical. So so the doctors, he can open the in-page or the documents, and then he can either call the patients or he can use this barcode screen here, and that will take him to open the camera on his cell phone, and then he can do the virtual consultation through his telephone, and then after that he can document in the system. I know Cerner, they are working to have, like some sort of virtual consultations to be like part of the MPage, but I don't know where they are at this time. But this is some of the initiatives that we are doing here at Sidra, but this is a working process. It is not live yet. But this is one of the ideas that I want to share with you. The other, and this is basically what you are going to get. So, so upon you scan the barcode, you can use your cell phone and you can basically do the consult, and then you can document in the system. So instead of doctors working on two screens, it is basically they will work mainly on one screen, and this will be more practical for them. I think that's it. This is some of the ideas that today I decided to share with you, and I'm happy to take any questions. The other things that I want to tell you is, as we are like a digital hospitals, and we do this innovation, but also we are working very closely with other health organizations like HMC, other organizations like Ministry of Transportation Communications and Ministry of Public Health, because also they support innovation. And sometimes there is projects that we work together to support because it will be like much initiative, and we have a lot of people. Like when you open it for other health organization and you increase the networking, you get more ideas, and you will surprise sometimes when you get ideas from non-medical team. Like IT or technical people, they have a lot of good ideas that it's very helpful to support health sectors. And vice versa. Sometimes even you can have doctors who they have ideas that can support different organizations. So we are trying to develop, like in Qatar, like a hub for as a national innovations. And the country identified the Ministry of Transportation and Communication as a hub, and they develop innovations lab, and they welcome all ideas there. So that's it. So this is what I have today, and I'm happy to take any questions.
This is Pat Brown. Thank you for the presentation. You mentioned that the public transportation and communication were part of the innovation partners. In your area, is there much emphasis on what we would call population health, where you're sort of looking at using nurse navigators or people in the community to care for populations of patients, in doing things like home visits or identifying other ways of communicating with patients who may have difficulty coming into the hospital?
Yes, we do. This is still not implemented, but we have these ideas. Like at the Ministry of Public Health, they are working now to have a partners, vendors to support a health information exchange platform. It's called HIE Hub, that basically is going to support all the national. But at the same time, they want to allow for a telemedicine to be part of that solution, where the public or the client, he can access and he can choose which health facilities or specialty that he wants to visit, and that hub will support this. So this is something that the ministry are working on, and I think this is probably like it may take maybe 3 to 5 years from now. But currently, we have the virtual consultations, and but we didn't allow like the self-referral at this time. But I think this will happen very soon. Currently, if the patient is supposed to have an appointment, so then we can do the virtual consult. But I think in nearest futures, we will allow like patients to call for the appointment and allow self-referrals. We have also a remote monitoring, especially for AKGs and also for blood sugar. So this is something that already exists. And we are expanding this now to do vital signs and others. So there is a lot of companies here who they are interested to support health, and they want to adopt this technology for virtual consultation and remote monitoring as part of the telemedicine. Regarding the public health, yes, this is one of the important topics that the Ministry of Public Health they are really looking for, and this will be also part of the solution of the health hub that will cover public health. And here in Qatar, it's very common. We have a very high endemic for diabetes and ischemic heart disease, and also road traffic accidents, and also. Currently, we have a lot of health strategies, and we want the public health to support this health strategy for 2022. And also there is the big strategy, basically, that Qatar is working on is for 2030.
Great. Thank you.
You're welcome. Thank you.
This is Dr. Mandy Hall for Covenant Health. I just want to thank you. That was an outstanding presentation, and I couldn't agree more. It's been challenging, but also fun and exciting to see all the digital advances in response to COVID, and appreciate you sharing your progress with us today.
Thank you. And also I want to thank you for for giving me this opportunity to present this to you, and I'm happy to take any questions. And I think this is, like an opportunity to share and exchange informations to support, all health organizations to achieve, like the best achievement and help our patients.
Absolutely.
Great. Well, thank you again. I do have the slides that Dr. Khalid went over today, so I can make sure that those get sent out as well. If you're okay sharing those, I can send them with the meeting minutes, so people can have a chance to look at those as well.
Sure, there is no problem. Of course.
Thank you. And thank you again for presenting today and taking the time to put that together and discuss some of the cool innovations and things that you are doing to reach out into the community and keep your population safe.
Thank you. Thank you, Brian, for giving me this opportunity. Thank you.
Of course. So like I said before, we don't have Dr. Callison available, so I was going to open it up just to the general population here if you wanted to talk about anything, any roundtable discussions or general questions that you had, so we could discuss it as a group. I had one from Dr. Clark. I don't think he's on yet, so we can hold that until he gets on, but I didn't know if anybody else wanted to discuss about any certain topics or raise any questions that they may have.
So this is Pat again. I'll put out a quick question. We got news about the delay in the enforcement for the clinical decision support for radiology. We're at my last hospital system, we had actually rolled out the radiology clinical decision support tool for the organization by the end of December, so that we were ready to begin the testing year in January. Centra was a bit more delayed, and we're just now in the process of rolling it out. There were some questions yesterday about should we delay, and I'm of a mindset to just keep moving forward, even though the tool we have is ACR Select, which is not perfect, but certainly not a showstopper that seems to be that much of an impediment to care. So I'm proposing that we continue to move forward with the rollout, despite the fact that the penalty phase has been moved out a year. Just curious to know if other people are doing the same, or if you're putting the brakes on things.
This is Dr. Mandy Hall for Covenant Health. We are pressing forward. We're live in the ED. Went live for outpatient a couple of months ago. The only thing we haven't done yet is our observation, and we're going to move that out a little bit further towards the end of the year, but we're still planning to press forward. And on Dr. Callison's behalf from the University of Tennessee, they've been live, if that helps.
Yeah, thanks. I suspect
Grace from.
Go ahead.
This is Grace Wu from Murray Regional. We went live at the beginning of the year, and we did it across all venues, ED, inpatient OBS, and the ambulatory setting. And I don't feel like there has been much of an impediment in workflow. I haven't heard many physicians complain about it too much. So unless you have other barriers to moving forward, I think it's good to get your physicians used to the process before it becomes mandatory.
Yeah, that was our rationale as well.
And Dr. Brown, I'm sure you've done this before in your previous role before moving to Centra, but there were a lot of challenges we were going to have with the ambulatory workflow, and really had to put some customization in place because we do require the ICD-10 to be associated to our, and kind of pre-populated that into the reason for exam. So that would have been a huge step back for us if we hadn't worked out some of those issues ahead of go live, just in case that's helpful.
So I'm curious now, because we did, except for our power plans, we do not pre-populate an ICD-10. I mean, it's a requirement. It has to be there for the order to go through. But did you say you actually pre-populate that in all your orders?
Well, for ambulatory in our physician practices, instead of just doing a generic reason for exam order detail on the medical imaging exams, we require that they do associate a problem, an ICD-10, and then we had a custom rule that was sending that to the reason for exam. And there were just some, I think Cerner's fixed all of these now, but there were some issues on how AUC worked on the quick orders page. Mm-hmm. That we had to work out some of those details in order to make it a success for ambulatory. Wasn't a problem, to your point, for ED, and certainly won't be a problem for observation, but ambulatory is just a little bit different.
That's interesting. Thanks.
Does anybody else have any questions they wanted to bring up? If I haven't seen Dr. Clark on, I know he wanted me to ask this. I will try and ask it, and hopefully it makes sense. One of the things that he's done with his advanced providers is he has built them under their own position as opposed to putting them under the provider position. And he said that was a recommendation Cerner had given them for the PSO. And I believe he just wanted to know how others have built their advanced providers, whether you have them under their own position or if you just have advanced providers under the provider position.
This is Chris Deflich at Penn State. I think maybe this is maybe state dependent. Our NPs and PAs have different state requirements for oversight and signature. So we actually have NPs different than PAs, different than midwives, different than CRNAs, different than physicians.
That would be the same for Covenant Health as well.
Great. Yeah, we're doing the same at Centra. They have unique positions. Sorry.
Okay. Perfect. Thank you for that. I'll make sure I get that passed on to him. I'd had is one of the items that we wanted to talk about on a future agenda was orders to scheduling, and then how hospitals utilize that functionality and workflow. And I don't know if we wanted to talk about that. I know that's something that a lot of organizations struggle with. So, and we had previously wanted to talk about it. So wanted to throw that out there if that's a topic we wanted to get into today or come back to that on a future discussion.
I mean, we used it at Mission Health with our radiology studies. It was very problematic when we tried to use it with oncology, but it worked out very well with radiology. To my knowledge, we've not implemented that in at Centra yet.
Okay.
This is Chris Stiflich. Does that include the future orders activity?
No, this was different. The future orders activity had always been turned on when we turned on orders. The orders to scheduling was one that would really, it removed a lot of the manual work that our schedulers were having to do of transcribing information from an order into a scheduled visit. This allowed it to just carry forward. And I think for both future and active orders, but the radiology orders were a little different because there wasn't so much a date attached to that. The date was more dependent on what the scheduler would put in, if that makes sense.
Yeah, it does. We've had orders to scheduling for a while now. We've delved into future orders with a conversion to RadNet 2 years ago, 3 years ago, something like that, and run into some unique workflows related to future orders and cancel reorder and that sort of stuff.
The cancel reorder is what killed us in oncology. Any change in the schedule would just throw off every other order, so it was very problematic.
Yeah, we're just starting to go down that path now, so I may be reaching out to you.
Can you elaborate on the oncology in rescheduling, because we're actually trying to go live with our oncology clinic coming on to Cerner. And I just wanted to understand a little bit more about what the issues were for you.
The issues we experienced at Mission was, I think, part a workflow, but also part of this, how the tool was designed. But the providers felt like they wanted to make sure that they were signing off on all orders. And so if you put in a very complex power plan for a patient, scheduled chemo visits and then scheduled radiology lab and so on, those were all timed. And which happened often, a patient couldn't get a ride or had a fever and couldn't come in, they would have to cancel that and reschedule it. And when you did that, it ended up having this daisy chain of canceling, rescheduling everything else in that order set. And so the providers were just being overwhelmed in their inbox with having to sign all of these cancellations and reorders, and they just became overwhelmed. It was very hard for our front office staff to find a way out of that until they, it was either turn off the alerts for the providers or kind of rework how we were doing some of the orders to scheduling for the long-term care of the oncology patients.
Thank you for that. I'll have to get back with our team and make sure they have tested that one through. Thank you.
Brian, this is Dr. Halford from Covenant Health. I do agree that it would be great to have a discussion. We're live on future orders in the outpatient side and live with orders to scheduling, and didn't have this exact same problems that Dr. Brown described, but we did have a lot of issues. I feel like we're in a much, much better place now, but it would be good to just kind of regroup and see what things we could share as best practices or what things we potentially need to get back to Cerner for feedback on development.
Yeah, that's great. Maybe what we can do is we can put that on the agenda for, let's see, I guess it'd be October would be our next meeting. Maybe we can put that on there and people can take that back and kind of come up with some thoughts around future orders and orders to scheduling.
Sounds great.
I like that. Perfect. Well, I'm not trying to keep anybody longer than we need to, but is there anything else people wanted to discuss?
just had a quick question for the group about Clipboard and patient questionnaires. We've dabbled in it, I would say, with variable success. We've gone on a big journey to convert a whole bunch of recently acquired non-Cerner EMRs to a standard platform, and looking to move a little bit faster on that. Does anybody have a lot of experience in questionnaires and Clipboard?
This is Dr. Alford. We're just dabbling as well.
Yeah. We had done a pilot of it at Mission Health, and it really didn't advance beyond just a couple of clinics. Part of the issue, I think, this is from memory, but we had some difficulty setting up unique clipboards for just specific groups. Like cardiology wanted their own set of questions that neurology didn't want, and initially it was hard to get that carved out without the patient seeing everything. Another thing, and this is probably a parochial issue that we experienced just at Mission, but when we were doing the transition of care documents, the CCDs, they made a decision to actually send the CCD documents internally as well as externally. This is for the promoting interoperability. And we found that when we turned on the Clipboard, because we had been accepting so many of these CCDs and just sort of keeping them in the background, when we turned on eClipboard, we had tons and tons of duplicates of medications, problems, allergies in the system. And so that cleaning that up was a real chore. And we ended up having to turn off the internal sending of CCDs just to make eClipboard work. So that's, I don't know if that's something that was unique to Mission or if other sites would see that too, but that was something that we had not anticipated with eClipboard.
We are actually re-engaging on the Clipboard. This is Paul Clark, re-engaging on the Clipboard. We actually had a presentation from Truman Medical Center here, who has really successfully used it. When we tried it initially, the workflow challenges were what prevented us from deploying it, but we got a lot of information from them, and I'm going to re-engage.
Thanks. It sounds like a lot of people are on the same path that we're on. We've had interest in uniquenesses. I challenged our medical group leadership today with the ultimate question: why are we asking these questions? And I said, give me a list of why we're asking the patients all these questions for real, especially given the E&M coding changes that are going to come in 2021. Hopefully that'll provoke a little bit of a real look at why we do certain things.
Yep.
Paul, thanks for joining us. I did ask your question, I think, before you joined about your advanced provider and the physicians, and the feedback I got was everybody else has those as different positions, NPs and PAs, and some of that's driven by state requirements, but organizations have those built separately.
But do people have them built by specialty? So in other words, I have let's say a nurse practitioner works in cardiology or pulmonary. Are those built out as separate positions?
So hey, Paul, this is Chris DeFletcher from Penn State. We do.
You do, okay.
We did that mostly because of the revenue cycle activity. There's some really unique features in Pennsylvania related to individual NPI and group NPI numbers associated with professional bills. And in order for the NP in vascular surgery to bill under the correct group NPI, we had to build them out by position. So it wasn't necessarily related to PSO, but it was more related to the billing stuff, although that may be somewhat related.
Yeah, the PSO drove us to just create this one position. It came at the 11th hour, so we didn't have a chance to build out all the separate positions. But what's happening now, we're trying to use passive alerting with Smart Zone, but we're trying to tailor them to the right groups. So we have difficult intubation was one of them, and we don't want to show that to every advanced provider, but the ICU nurse practitioner needs to be able to see that. So that's really where it came up again, and we're just curious how people dealt with it.
All right, is there anything else? One thing I wanted to make everybody aware of is, so this session is being recorded. I usually put these out on YouTube. So if you want, you can go and listen to that afterwards. Also, if you go to makesolutionsinc.com, there's a roundtable link there, and you can get back to our meeting minutes, and the past meeting minutes are all stored out there as well. I put the minutes there, and then any supplemental materials as well. One thing that Patty and I are working on trying to do is have a site information guide out there, so you can see what other organizations, everybody who joins this meeting, what they have for their Cerner code and what they have in the lab department and the radiology department and that. So it's still a work in progress. We're trying to do that, but we want to make sure that you have that information available to you. That way, if you're questioning, you know, what am I doing in the lab here? Who's like me? You can go out to that list and be able to look at it. So that is in the works, but everything else in terms of previous meeting minutes and that is all stored out there on the website. So you can go look at any of that, so you don't have to try and find it in the emails. Let me know.
Brian, could I ask one more question?
Yeah, of
I
course.
joined late, but I'm going to still ask questions. So
go ahead.
The recent ruling of putting out the requirement for clinical decision support for radiology, have people going to delay, or have they already implemented, like ACR Select or whatever vendor you're going to use?
Yeah, that must have happened. Just that question was asked just before you got on.
Okay.
Yeah, and well, also I think the general feeling is about half the organizations have it implemented, and the couple that haven't are still going to go ahead and move forward with it, so providers can get used to it. Anybody feel free to jump in and provide any more context.
No, I think that was the consensus.
Okay, thanks.
All right. If there's nothing else, I'll give everybody back about the 30 minutes. Again, thank you, Dr. Khalid, for presenting to us today. We really do appreciate it. And everybody else for taking the time to join and ask the questions. Like I said, we'll get all this stuff sent out to you as well, so you can have it to reference as well. And we will talk again in 2 months. Thank you, everybody.
Thanks, Brian.
Thank you. Thank you.
Thank you.